have trouble hearing me. I've been told I have to stand in this spot. It's going to be very difficult for me. I like to move around.
Sorry about that. That's my bad.
Perfect.
Great. Can you make that looking go?
Yeah.
All right, as Dr. Whitworth said, my name is Tracy Timmons. I came to Peace Health in May from Shock Trauma at Baltimore. Why I came to Peace Health, at Shock Trauma, I admitted between 20 and 30 traumas every 24 hours when I was on call. We were a little bit busy, and after about 4 years of that, it's nice to go someplace where every now and then I can breathe in between the trauma. As Dr. Whitworth also said, I'm going to give you my street cred. I was a professional firefighter and paramedic for 7 years in Prince George's County, which is right outside Washington, D.C., all the finer parts of the east side of Washington, D.C. So I did a little business as a medic as well. I was only a mediocre fireman, but I was a decent medic. I never should have left that good union job, so if any of you want to come up and ask me if you should go to medical school, the answer is no. Take your 20-year retirement and then become a PA.
Here's your point. Here's the pointer right there.
All right, good. All right. If I'd known what I was getting into before I was in too much debt to do anything else, I never would have done it. But with that being said, I do love my job as a trauma surgeon. And it's pretty close to my roots as a firefighter and a paramedic, so I think it was a natural fit for me to end up doing trauma surgery. I also really like to teach. I came from a teaching institution at the University of Maryland Medical School where I was an assistant professor of surgery. So I've been teaching residents and medical students, and so I actually volunteered and asked to get to do this to you, so I have inflicted myself upon you. With that being said, I would really appreciate any feedback you can provide to Mark or to Dr. Whitworth about anything you'd like to see in the future, if you'd like to have me back. If you hate it and you don't want me back, it's okay. I'll only cry a little bit. Okay. So I'm going to start with a case that comes from Clark County in the very recent past, I think about the 1st of December. I'm going to call this fellow Flash Gordon. And Flash was in Camas at the Moose Lodge having a beer, I guess, and decided to walk out of the Moose Lodge and directly into the street in front of a Ford pickup truck. It did not work out so well for Flash. When EMS arrived on the scene at about 6:30 that night, they found Flash with a GCS of 3. He was lying under the vehicle. They thought he might be trapped underneath the vehicle. His jaw was clenched. GCS 3 means he wasn't moving anything. The medics who gave me a report when they arrived to the emergency room very rightly thought that he probably had a pretty severe brain injury, and I tended to agree with them given his presentation on the scene. He also had lacerations to his face, a deformity of the right leg, and you can see his vital signs there. Heart rate 74, so that's not so bad, right? Not looking like a guy who's bleeding a bunch. Not looking like a guy who's in a lot of shock. Blood pressure 100s over 70s, respiratory rate 22. They did intubate him en route when they got an entitled CO2 of 45, which is good, so yay medics for that. And they arrived at Peace Health at about 7 o'clock, change of shift, which is exactly the perfect time to arrive with a trauma. In the emergency room, his heart rate's a little faster, his blood pressure's a little bit lower. And eventually he starts to localize to pain. His pupils become more responsive. Initially, they were unresponsive, about 5 millimeters. But they start to become at least sluggishly responsive. So I'm also now thinking this fellow's got a pretty good head injury, but we're going to do a good traumatology workup. At the end of his evaluation, these are the injuries that he has. He has an LC pelvis fracture, which is a lateral compression pelvis fracture. So where he got hit by the truck on the right side, that side of his pelvis was pretty much crushed. It involved the acetabulum, which makes it a little bit more of an orthopedic injury that's exciting for the orthopedic surgeons. He had a pretty complex right tibial plateau and fibular head fracture, subarachnoid hemorrhage, so he did have a head injury, pneumothorax on the left, for which I placed a chest tube, which is when I discovered that he was localizing to pain because he didn't like that so much. He had a urethral injury, and Unfortunately, unlike the textbooks, he didn't have any blood at the meatus, no scrotal ecchymosis or swelling, which was unfortunate. He just had a lot of frank blood come out of the Foley once we got it in. And then he had multiple lacerations. So this is his head injury. This is his head CT. And it's really not that bad. So I saw this head CT and I saw that little bit of blood there and I thought, oh my gosh, this guy doesn't have a terrible brain injury, right? So I want to talk a little bit about traumatic brain injury, okay? The leading cause of death after trauma, number 1 is TBI. Number 2 is hemorrhage. And then should you live long enough to make it 5 to 7 days in the hospital with your severe trauma, the third thing that kills you is sepsis. And TBI has a very nebulous definition. It's a blow or a jolt to the head or a penetrating head injury that causes a disruption in the function of the brain, or so it causes some brain dysfunction. So unfortunately, it may not show up on a CT scan. You may not see anything externally. It may show up only on an MRI or not at all in any imaging. It may result in unconsciousness, or it could just be someone who, has their bell rung, somebody who seems a little bit confused or dazed. And in terms of severity, the injury of severity ranges from mild to severe. And we base that in medicine on the GCS. And the reason we do that is because we're not really very good at measuring how people's brain works in the field or in the acute hospital setting. So we have a gross scale, that's the GCS. So 3 to 8 is severe injury, 9 to 12 is a moderate injury, and 13 to 15 is mild injury. But for all intents and purposes, if you're doing a GCS, what matters for the patient and for their outcome is this motor score, okay? So a lot of these folks, like our fellow, will have lacerations to the eyes, they'll have facial trauma. They may or may not be able to open up their eyes. Once you put the tube in, they're clearly not going to talk. And the motor response is really where it's at. So patients who have a 6 or obey commands on the scene, they're probably going to have a pretty good outcome, provided their condition doesn't deteriorate. People who localize on the scene, they have a good shot at getting better and going on to lead a normal life, being able to have a job and all of that stuff. Once we get down into the withdrawals, flexes, and extends, those are folks that unless they have something that is acutely fixable in their brain in terms of their trauma, they're probably not going to have such a good outcome. And if you look at the GCS coma score here, severe injury is 3 to 8 and moderate injury is 9 to 12. Well, once you get down to That's okay.
Do what I say. There we go.
So once you get down to you lose a couple points here, and maybe you lose a couple points here, and you lose a couple points here, you see that you're at severe and moderate pretty quick. In terms of how bad this problem is for us, 1.7 million people sustain a TBI every year. 52,000 will die. 275,000 will be hospitalized. 1.4 million will be treated at the emergency room. And again, it's the leading cause of death and disability in children and adults ages 1 to 44. So people in the prime of their life who have the most opportunity to contribute to society. And it costs us a lot of money. Yeah. I'll just make a point that in Maryland, one of the legislators suggested that because people died more often if they didn't wear helmets when they rode motorcycles, that there should not be helmet laws because it would be cheaper to take care of the patients who crashed their motorcycles. I'm just throwing that out there. As trauma surgeons, we cannot endorse that. All right. I'm a quick learner.
Good job.
All right, so the leading causes of TBI: falls, crashes, struck by and against. In Baltimore, this was usually a baseball bat or a tire iron, sometimes a rock or a brick. But it can be anything. It can be the wall that you beat your head against in the morning. And then assaults. And like our fellow Flash Gordon, a lot of patients who have a traumatic brain injury will also have multi-system injury. So these are patients that are going to be complicated to take care of. For the most part, they have a lot going on. 5 to 10% can have an associated spinal cord injury, and the TBI will contribute significantly in 75% of all trauma deaths. Only 25% will have a surgical lesion. And I'm going to get into this a little bit further. I have pictures, because I like pictures, that shows you what surgical lesions are. And these are things in the brain that the neurosurgeon can take to the operating room and help the patient out. All right. Primary brain injury, this is what happens when the injury occurs. So when Flash got hit by that Ford Ranger, he suffered his primary injury. Unfortunately, the only thing we can do about primary injury is prevent it. So we can have children wear helmets on bicycles, which I notice they don't do so much here. We can have them not crash their motorcycles or not fall off ladders. Other than preventing injury, there's not much you can do about primary injury. It's caused, again, either the head strikes something solid or impulsive loading, which is when you get sudden movement of the head even though the head doesn't strike something. And we'll talk a little bit about that. And that's usually a hyperflexion injury, sometimes seen in car crashes when the patient's seatbelt works really well, holds them in place, but their head still goes forward and then back quickly. So there's that brick wall. And just a quick review, because I'm going to show you some CT scans here, and I want you to have an idea of what we're talking about. This is the bone of the skull right here. This membrane right here is the dura. So this space outside the dura is the epidural space. That's where you get your epidural hematomas. When I was in paramedic school, they described that as a patient who had a lucid interval and then became unresponsive. So someone who might have been knocked out, they wake up, they seem to be acting right, and then their GCS deteriorates. I was looking for a percentage of patients who actually present with that, and I couldn't find one. But I can tell you when I was a medic, I had a 12-year-old kid do that. That's my one story. And then underneath the dura, you have the subdural space, right? So this is the space between the dura and the arachnoid, and that's that spidery-like web of stuff that covers the brain. And then you have your brain matter here. So here's the pictures I told you about. So epidural hematoma, a lot of times associated with a skull fracture. This is going to be a blunt blow. The nice thing about this is it gives you that, what we call the lentiform picture. So you can see that nice concave, looks like a contact lens right there. These tend to get worse fast because they tend to be arterial bleeding. Okay? And that would account for why you have the lucid moment. And then as the lesion gets bigger, it causes unconsciousness and it gets bigger quickly. And that would be one of the surgical lesions. Patients who come in that have a low GCS, if they have an epidural hematoma, a lot of times neurosurgery will take them and evacuate that hematoma and allow their brain to expand back into its space. Subdural hematoma. So this curves along the skull. Okay. These can also be treated surgically. They tend to accumulate slower because they tend to be venous bleeding instead of arterial bleeding. This is the classic type of injury that you'll see in somebody who's elderly who falls down. And a lot of times, because as we get older, our brains shrink, there's lots of room inside the skull, and so these folks can accumulate a decent amount of blood before you start to see symptoms. In other words, they won't necessarily be confused or have an altered mental status or a change in their GCS, in spite of the fact they can have a significant amount of blood in their head. And then intraparenchymal contusions. These are rarely able to be fixed surgically. So this is blood. All this bright stuff is blood right here. And this is within the actual brain tissue itself. It causes damage right to the cells locally. It causes compression of the brain tissue that's surrounding it. But it's hard to get to surgically and fix it without doing more damage. And then subarachnoid hemorrhage. This we see a little more diffuse blood around. and then intraventricular hemorrhage, and this is an MRI, where you see the blood within the ventricles of the brain. Typically, an intraventricular hemorrhage is associated with a worse outcome. And then kind of the bugaboo of neurosurgery and trauma is diffuse axonal injury. So this, we think, is a shearing injury, and this is where that hyperflexion, where the head doesn't strike anything, comes into contact. So with the severe fast flexion of the head forward and backwards, all of the neurons get stretched. And what we think happens is that these little areas here that bleed are from the injury, stretch injury, and then those cells die and become these little black spots all over the brain. So it's a diffuse pattern. It's not in any one location, so it's called diffuse. And we don't have any good ways to treat it. So the patient's going to present how they present, and often how they present initially from their diffuse axonal injury is how they are going to present for the rest of their recovery. So this is a bad one. All right, so now we get to the meat of what you can do and what I can do, because all the neurosurgeons in the audience, raise your hand. Okay, so none of us can go to the operating room with those lesions and take that blood out of the head. But this is what you and I can do. We can prevent secondary brain injury. Oh, and I forgot to warn you, I try and make the first 20 minutes of this what you really need to know. The last 20 minutes of this is a little bit of extra stuff about what we do in the hospital. So those of you who want to go to sleep for that part, I understand, I won't be offended. But it's just a little extra information for you. So secondary brain injury, it's difficult to predict. It's difficult to image. We don't really know who it's going to happen to. We don't know which injuries are going to have that happen to them. And what we do is we try and prevent this. Okay, so prevention is key here. We think it happens from cellular damage. So the initial injury occurs, the cells get damaged, and then as those cells either die off or don't function properly, we start to see secondary injury. It can develop over hours to days. Sometimes we can see this occur 2, 3, 4 days later in the hospital, where a patient's GCS goes rapidly downhill. And that's oftentimes associated with swelling and ongoing damage from their brain injury. Again, it's mediated through some chemical and cellular mediators. We have the obligatory complex cartoon over there that's going to show you the biochemical processes that we think this happens through. It can cause edema, so you get swelling. Anytime you have an injury, your body likes to send a fluid there and cytokines to cause inflammation. So you get swelling. That swelling can reduce blood flow or reduce venous return, and so you can have ischemia. And then disturbances in the intracellular ions and how the chemicals in your brain are moving across the blood-brain barrier or even across the cellular barrier, as some of those intracellular junctions get a little leaky. And then, worst case, you get to necrosis and apoptosis, which means the cells are dead. And once the cells die, that's pretty much it. You're done. Well, those cells are done. And how many of them you have to lose will determine your outcome from your injury. So in the field, your signs and symptoms of TBI: altered or depressed level of consciousness, an asymmetric motor exam, pupil abnormalities. Okay, one pupil's big, one pupil's not. External trauma. If you see a big contusion on the scalp, there might be a head injury underneath that. Raccoon eyes and battle signs, those are late signs. So if you see that, I'm guessing the patient's been laying there for a little bit, or their trauma was 2 days ago. And then mechanism. This is, something that you guys often apologize to me as you come in telling me how when the patient looks good and you say, well, it was kind of a soft call, but mechanism is important. And like I said, these TBIs, sometimes they don't show up right away. So you're never going to hear me ding you for bringing someone in that has a good mechanism for a traumatic brain injury, especially our elderly folks. Old people fall down and bleed in their head. Okay. Loss of consciousness or amnesia, nausea and vomiting, those are good ones that you should see in the field. And you may have a patient who seems completely appropriate, but then they develop nausea and vomiting. In my book, that patient has a head injury until we prove otherwise. And we probably won't prove otherwise, so I'm going to give them a diagnosis of a head injury. And then repetitive questioning or perseverating. All right. So in terms of what you can do in the hospital, you want to prevent hypoxemia and hypotension, because those are mediators of secondary brain injury. When the brain doesn't get enough oxygen and it doesn't get enough blood, you have ongoing damage after your initial insult. So supplemental oxygen should be administered, and you should monitor your sats and make sure you maintain them over 94%. This is a study from the Journal of Trauma in 1999. So it's a little bit old, but unfortunately we don't have a lot of new data that's different, that shows that on patients with an oxygen saturation of 90% or greater in the field, had a 4.8% of severe disability, 14.3% rate of mortality. Less than 60% in the field, your mortality goes way up, your severe disability goes way up. Now, these are some small numbers here, but pretty significant differences in outcome. This is actually one of the kind of seminal studies by Chestnut, who's a neurosurgeon who does a lot of TBI work, that looks at hypoxemia and hypotension in the field, and patients who had neither of those and patients who had both. That pretty much speaks for itself. And again, these low numbers when you get down here, but a decent number of patients overall. So what can you do? Airways should be secured in patients that have a GCS less than 9. There may be people who would argue that a little bit higher GCS would warrant intubation, and I probably wouldn't disagree with you on some of that. If the patient can't maintain their own airway, I think it's reasonable to intubate them. If their hypoxemia isn't corrected with oxygen, if you can't oxygenate them adequately, then I think you need to intubate them. And if you can't ventilate them adequately, you need to intubate them. And we'll talk about a couple of studies that looked at field intubation. As a medic, I intubated a lot of people, but we didn't have RSI back in the day. So if they had a gag reflex, I probably wasn't going to be successful. And if they didn't have a gag reflex, then it may or may not have made a difference. But this is a study done by Grant Pacchicchio. He's one of my colleagues at Shock Trauma. He did this study back in the early 2000s, and I'm going to give you the caveats right away because I didn't actually like the results of this study in spite of what the study shows. My caveats are this was done in Maryland mostly before we had transport ventilators for the medics. So most of these RSI folks are coming in being manually bag valve mask ventilated and oxygenated. Okay. But they looked, and it was not a randomized controlled study. So it was just a prospective study looking at patients who got RSI'd in the field.
Can you click back to your lapel?
I can, but it doesn't seem to work.
I'll get it.
Okay.
Go ahead.
Okay. Can we keep talking?
Yep.
Can you hear me now?
Yep.
Can you hear me now?
Yep.
Okay. All right. So unfortunately, what this study concluded is that pre-hospital intubation was associated with a significant increase in morbidity and mortality in trauma patients with a traumatic brain injury. Now, what I think is going on with that, my personal take is, number one, when you don't have a mechanical ventilator that you're transporting, that means somebody's doing this, right? And if there's a lot of adrenaline and the patient's kind of sick, it gets really easy to go from 12 to 14 breaths per minute to about 24 or 28 breaths per minute. And I can tell you as a medic, when I brought people in, especially young people or people who were really hurt or really sick, they were ventilated because in my day, we didn't learn about TBI and how to manage it very well. And if a little bit of oxygenation and ventilation is good, well, then a lot is more, right? So if you have a 1-inch hose, it's better to have a 2-inch hose. All right. So I think that contributes significantly to the results of this study. And again, it's not a randomized controlled study, so it's not great data, but it's what we have. Unfortunately, we have a little bit better study done by Davis et al. There was a randomized controlled study that looked at mortality in RSI patients and some matched cohorts. And it also found that RSI was associated with an increase in mortality compared to historical controls. But it was associated, the association was with hyperventilation. So remember I said I thought you could go from 16 breaths per minute and probably an end-tidal CO2 of 35 to 40 to an end-tidal CO2 of 20 really fast. If you're doing this, I think this is what the study shows. And then patients who were transported by helicopter had improved outcomes. And my theory on this is it's because they got to the hospital faster, so they were less likely to have their end-tidal CO2 drop down into the 20s. They just didn't have time to get there. It would be nice to have some randomized controlled studies now that we have ventilators, and now that you all get training on how to manage TBI in the field to see if there's a difference here. All right, so in terms of options, a lot of times you hear about prophylactic hyperventilation, and that's bagging somebody down so that their end-tidal CO2 goes down and so that the pH goes up in order to decrease blood flow to the brain and decrease intracranial pressure. Unfortunately, we think that's a bad idea. Based on those two studies I showed you, as well as some other studies in the hospital that look at hypoventilation and hyperventilation, unless you're doing it to prevent an impending herniation, meaning the patient's pupil just blew right in front of your eyes and you are pretty sure that right now they're going to herniate, don't do this. I don't even like doing this once the patient arrives in the emergency room. I think there are other things we can do that are more effective. Fluid resuscitation, you want to do this to avoid hypotension. So go back to that chart I showed you where if the patient has hypoxemia and hypotension, they have a much higher chance of dying. So making sure that they are not hypotensive helps their brain. You're going to walk a fine line here because if you bring this patient in with a grade 5 liver injury who's bleeding, I don't really want you to have their blood pressure in the 120s because all you're going to do is blow that clot off their liver and they're just going to keep bleeding. That's going to make my day hard. However, just keep in mind, with patients you suspect they have a traumatic brain injury, you need to maintain blood pressure, avoid hypotension. The most commonly utilized fluid are isotonics, so normal saline and lactated ringers. Those are good things in the field. Do you all have hypertonic saline in the field? Anybody have 3% or 7.5% saline? Okay. So pre-hospital hypertonic saline has been looked at. You know, if we give it this to, and we use this in the emergency room, and I'll talk a little bit about how it works here in a second. Wade and his colleagues took a look at whether or not pre-hospital hypertonic saline was beneficial. And they found that patients who had traumatic brain injuries and hypotension who got hypertonic were about twice as likely to survive as those who received standard normal saline or lactated ringers. So it makes you say, great, right? So we can carry 3%. It doesn't take up as much room. It's not as heavy. It's a good resuscitation fluid. It makes the brain better. Except that Cooper and his colleagues looked at pre-hospital hypertonic saline and found that there was almost identical neurologic function 6 months after injury as patients who received conventional fluid. So again, the data is not convincing to use hypertonic saline. We do use it a lot in the emergency room, and we'll use it a lot in the ICU in patients who have elevated ICP. But what you should be getting from this talk is that the majority of what we do to take care of brain injuries has nothing to do with the brain. Right? It's maintaining normal physiology the best we can, maintaining normal oxygenation, maintaining normal ventilation, and maintaining normal blood pressure. For you guys, the initial evaluation is always the same for every trauma, A, B, C, and this counts for traumatic brain injuries as well. And again, we talked about intubation, low GCS, and then, you know, that motor score. If the patient isn't localizing, certainly consider intubation. Ventilatory insufficiency, hypoxemia, hypercarbia, decreasing level of consciousness, and probably there is a role in patients who are agitated, depending on how agitated they are and whether or not you can maintain good oxygenation and ventilation and can transport them safely. We tend to intubate people in the emergency room for this so we can get them to the CT quickly and take a look and see if their agitation is baseline personality or if their agitation is from the head injury that we suspect that they have. Again, maintain euvolemia, so prevent hypotension with isotonic fluids. And you want to avoid glucose-containing solutions because when people have a brain injury, that blood-brain barrier gets leaky if all that sugar gets into the brain cells themselves, and then that sugar draws fluid in, increasing cerebral edema. There's also a question of whether or not glucose on the brain cells themselves can be damaging in and of itself, if the glucose itself is toxic to the cells. So GCS, don't be shy. Okay? If the patient does not follow commands, what I want to know when you come in is, are they localizing? Are they withdrawing? I'll probably be able to see if they're flexing or extending. All right, so to tell if somebody's localizing is crossing the midline to get to the source of noxious stimulus. Okay? So a pinch down here doesn't really help because there are spinal reflexes that when you cause pain on an extremity will cause the extremity to pull away. So you want centrally located pain, all right? Don't be shy. Centrally located pain, a really good twisting pinch, a really good sternal rub. The patient needs to feel the noxious stimulus, and then you want to watch and see, do they take a hand and come across to get to you to make you stop doing that? Okay, that's localizing. Or do they do this, and that's withdrawing, and then bad signs, flexion and extension, right? And honestly, these are nice. I like those, the verbal score. I-score, I'm not really sure what that means in the context of an acute injury with patients who often have a lot of facial damage. Just a note. If I ask you for a GCS, that is not part of it. Okay. It's important for your neuro exam, right? It's good to know whether or not a patient moves everything, because one of the signs of a brain injury is that they have a focal exam, meaning they're not moving a right arm or a right leg or both. So I want to know, but it's not part of the GCS. And then pupils. The big thing is, are they equal and are they reactive? All right, so if they're equal and they're reactive, that's a good sign. This is the blown pupil that goes with an impending herniation. So if you see that, you should be thinking something like this. And what's happening here is all of this blood is pushing on the brain, and it doesn't have very much room to go anyplace. And so it sits on the tentorium, which is shaped kind of like this, and it has a little hole in the middle. And that side of the brain that's getting pushed is trying to squeeze down through this hole. And it's compressing cranial nerves, which control pupillary dilatation, and that's why you get the pupil that blows up when you get herniation like that. And to treat that, well, for patients that have bilateral pupillary disturbances, that can be hypotension, hypoxia, it can be drugs. A unilateral one should make you very suspicious for a head injury, and this head injury is going to be something that's surgically treatable. All right, the Monroe-Kelly doctrine. The cranium is a fixed space. Your skull is hard. There's only so much room inside it. There are three things that have to fit there: the blood that feeds your brain and drains the bad metabolic waste out of it, your brain cells themselves, and the cerebral spinal fluid. If any one of those components starts to take up more space, one of these other components has to take up less space. It's why you have problems with patients who have swelling in their brain. So the brain tissue starts to swell with fluid, it starts to take up more space. If there's no change in the CSF, if the CSF can't go anywhere, what happens is that the blood supply has to diminish somehow. So you get less blood up to the brain, which means less oxygen and less nutrients to help feed the brain cells, and that contributes to your secondary injury. Now, here's the part where I'm going to talk a little bit about what we do in the hospital more than what you guys do out in the field. And this is, if you have an idea, you bring your patient in, we think they have a bad head injury, you've told us you think they have a bad head injury, this is how we're going to start. we're going to start looking at what their neuro exam is. I am probably going to order hypertonic saline pretty quick, before even a CT scan. And the reason is, hypertonic saline, at least in combat in Iraq and Afghanistan, has been proven to be a pretty good resuscitation fluid. One of the things in trauma that we worry about are patients who are bleeding and who are in shock because they're bleeding. Remember, 50 to 60% of patients with head injury will have multi-system trauma, so it is entirely possible and frequent that you'll have patients who are bleeding to death in addition to having a head injury. And hypertonic saline is a little bit of, extra bang for your buck. You get the resuscitation, and you can decrease your cerebral edema. Hyperventilation, again, if there's impending herniation, and even with that, we don't want to blow them down below end-tidal of 35. Okay, so 35 is where I consider your prophylactic hyperventilation. Less than that, and I think you probably do more damage. Operative treatment of any surgical lesions. So when we get the patient to the CT scan, if they have something that their neurosurgeon can fix, we got to get them into the operating room and get that fixed quickly. But again, that's only 25% of patients who come in with traumatic brain injuries. So all of our TBI patients, we want to maintain a blood pressure greater than 90. That makes sure that we get blood up to the brain. We want to keep their hemoglobin 7, so we'd like that blood pressure to be oxygen carrying capacity, which the hemoglobin provides. Maintain a serum sodium greater than 140, and the reason is if the sodium controls water in and out of all of your cells. So a high blood sodium means that you're going to draw water out of your brain cells. So a lot of times our TBI patients in the ICU, we'll run them up to a sodium of 150, 155, sometimes as high as 160. We initiate DVT prophylaxis pretty early. And then nutrition, because one of the things that we do know works, we have some good evidence for, is that patients with traumatic brain injury benefit from early nutrition. And then anti-seizure medications. In the first 7 days following a traumatic brain injury, a patient is most likely to have traumatic brain injury related seizures. And so we can use phenytoin. We are moving towards Keppra. There are now some studies looking at Keppra relative to Dilantin in terms of treating seizures. The old data only ever used Dilantin as a treatment for seizures, and so that's why a lot of places will use Dilantin for seizure therapy, anti-seizure therapy. So who do we do this in? Who gets the anti-epileptics? People with a GCS less than 10, if they have a cortical contusion, especially a temporal one, depressed skull fractures, subdurals, epidurals, some intracerebral hematomas, some intraparenchymal ones. I have to say the neurosurgeons here are less aggressive about anti-seizure therapy for those than in Baltimore where I trained. And then penetrating head wounds, or if the patient has seizures. So if the patient has a seizure within 24 hours of their injury, and honestly within the first 7 days of their injury, they are now going to get treated for post-traumatic seizures. Initial intervention for management of ICP. So remember I said, you have a closed box, you only have so much space. When one of those three components in that box starts to take up more room, the pressure inside that box increases. And that pressure compresses brain cells and causes damage. So how do we control that pressure and maintain blood flow? So ICP has to do with the pressure in the box. CPP is cerebral perfusion pressure, or how do you get blood into those brain cells to provide nutrients and oxygenation and then allow blood to drain out of the skull so that the waste products can come out of the brain as well. Again, airway breathing and circulation, you guys do that, right? So maintain your PaCO2, again, 35 to 38. Supplemental oxygen so that we keep people's SATs over 90, 94%, and keep their PaO2 better than 70. Maintain normothermia. Now this is something you may hear a little bit about. There is an association with patients who are hyperthermic who have worse outcomes. Now, we don't know if their fever makes their outcome worse from their head injury, or the bad head injury is more likely to give them a fever and they were going to have a bad outcome anyway. But since we don't know, we treat the fever and try and keep the patients at a normal temperature. Keeping the head of bed elevated at 30 degrees helps with venous drainage. Okay, so if you get venous blood accumulating up in that box that's rigid, it doesn't allow for swelling of the brain. It doesn't allow for as much arterial inflow into that compartment. So keeping the head of the bed up lets that drain out. Again, we ensure good head and neck alignment. We've actually done studies that look at people who have ill-fitting C-collars or who don't have C-collars, whose heads hang down like that, and they have worse intracranial pressures and worse cerebral perfusion pressures just because of their head position. And then reduce unnecessary noxious stimuli and adequate sedation and analgesia. And a lot of times adequate sedation and analgesia will reduce unnecessary noxious stimuli. All right, so sedation and analgesia, a lot of the sedatives we give, especially things like propofol, will reduce the metabolic demand, and so reduce the requirement for that arterial blood that we're trying to get up to the brain. Decrease the metabolic rate of the brain, so the brain's doing less work, making less waste product, requiring less oxygen, and decrease blood flow. So again, you don't increase the pressure in the brain, and you help minimize expansion of one of those three components in the box. All right. In addition to fevers being associated with bad outcomes, it increases oxygen consumption. It can increase cerebral blood flow. Sometimes we do this. We don't, but the neurosurgeons put in a catheter, help drain cerebral spinal fluid. So going back to that box, if the brain's swelling and there's blood in there and you want to decrease some component in order to not prevent injury to the brain cells, you take the cerebral spinal fluid out. And that's what this contraption will do here. All right, I'm going to talk a little bit about mannitol. Mannitol is sometimes still used in order to treat cerebral edema. It is an osmotic agent, so what it does is it gets into your bloodstream, it draws all the water into your bloodstream, and then you pee it out. The problem with mannitol in acute traumatic patients is that it can dehydrate patients pretty severely, and if you have a patient who's already bleeding and hypotensive, the last thing you want to do is take their volume away. But it'll decrease your blood viscosity, it'll increase your cerebral blood flow, it increases cerebral oxygen delivery. So it's not a totally bad drug. We've been giving it in head injury patients for years, and it's worked pretty well. It does cause some shrinkage of the brain, again, from sucking the water out of the brain cells. Can take up to 30 minutes to work. And then it can open up the blood-brain barrier, and all of that osmotic agent goes into the brain cells, and then all of the fluid that you've just sucked out of the brain cells goes right back into the brain cells. You get increased intracranial pressure. Hypertonic saline, I've alluded to this before, we mentioned it. Similar to mannitol in that it'll reduce your intracranial pressure. Again, by osmotic effect, it sucks water out of the brain cells. It increases your plasma volume, okay, so it also makes your blood thinner and less viscous, just like the mannitol does. It provides a resuscitation effect and giving you a little bit of increased blood pressure. And it's less likely to cross the blood-brain barrier. Some more pictures here. So the picture on the left is before the administration of the named fluid, and the picture on the right is after the administration. All of this bright stuff is water. Okay? So when you give somebody hypertonic saline, you go from this much water to this much water. Normal saline, which is what we typically use on medic units, you go from this much water, an improvement still, and then if you don't do anything, right? So no change there. All right, so hyperventilation, we talked about prophylactic hyperventilation, it's not recommended. And this is the last thing that we have as an available option for treating head injuries, is the decompressive craniectomy. It decreases the ICP because it makes that box bigger, right? It relieves the pressure in the box. Increases blood flow, decreases cerebral vascular resistance. It increases your brain tissue oxygenation. And this is a picture of how it works. So you take that piece of bone off, you put the skin back over it, and now the brain has all of this space to expand out. Okay. So now all of that pressure that you had before trying to squeeze the brain through places it doesn't belong is relieved, and now the brain has some place to go so that you don't get secondary damage by compressing those brain cells. We have pretty good data at shock trauma that looked at decompressive craniectomy. However, I'm going to tell you the literature is pretty sparse on whether or not this actually helps people. Most recently, and I don't have the data here, most recently about 4 years ago, there was another randomized controlled trial that looked at decompressive craniectomy versus not doing decompressive craniectomy, and there was no difference in outcome or mortality. So this is a fairly aggressive maneuver. And given that the data is limited, it may or may not be taken on by particular neurosurgeons. I actually think it has to do with how they're trained and what their personal philosophy is. All right. And then kind of going by the wayside anymore is barbiturates. So my favorite is when you talk to the family members on the news and you watch the news and they say, well, they're in a medically induced coma. Most patients that we have who have TBIs are not in a medically induced coma. They're sedated. They have propofol on board and some fentanyl on board. This is how you do a medically induced coma. You give a patient barbiturates until they are truly in a coma. All kinds of bad things happen when you put a patient on barbiturates. They have an increased risk of infection, increased risk of pneumonia. You have to monitor a huge amount of them. So this is going by the wayside as a treatment for intracranial pressure. However, it can still be used if you have a patient who's just refractory to everything else you've done. You just can't fix it any other way. All right. So to sum up, I guess the key for you guys is that TBI is a multi-system disease. Patients who come in with TBIs will have organ dysfunction in a variety of systems. Patients in the ICU will often have respiratory dysfunction. They may have cardiovascular dysfunction, renal dysfunction, and hepatic dysfunction. This is just not with any other injuries, but just related to their traumatic brain injury. In terms of, conclusions here, our treatments should be evidence-based and protocolized, and I think that we pretty much do that. Again, it's a multi-system disease. You want to avoid hypoxia and hypotension. And then the key for all of us in the room, since we're not neurosurgeons, is that taking care of a TBI patient really means taking care of a lot of systems away from their brain, making sure that they're hemodynamically stable. All right, questions? All right.
What?
Sure.
I have a question.
Sure.
Everybody else is shy. In terms of the trauma service and these TBI patients and resources for managing them after the acute phase and getting them rehab. I know in the emergency department we see some of the patients that have had concussions from more mild injuries. But what do you have as resources in the community for recovery?
So outpatient treatment, especially after mild or moderate TBIs, is a little bit challenging. What we do is we'll see any patient who comes to the ER that you think has a concussion, that has post-concussive symptoms and needs to come see us. We're happy to manage those initially. Right now, there's about a 4 to 6 week wait list to get a COG evaluation, which is a cognitive evaluation. Remember the GCS is a very gross scale. Either you're pretty close to normal or you're pretty messed up. And there's not a lot on that scale in between. So a cognitive evaluation it takes somebody who's pretty close to normal and does a much more thorough job of how's your memory, can you do some simple math, can you remember these words, and it goes through a whole evaluation of really specific minor brain functions so that we can see how somebody's doing after a concussion. This is totally an outpatient issue because these are folks who wake up, they're alert, they're oriented, they can tell you what happened, but maybe they're irritable, they have mood swings, they have depression, they don't sleep, they can't recall easy, simple things from short-term memory issues. Oh, maybe I have a TB. No. So these are folks who are fairly functional, but still suffering symptoms from their TBI. So they'll get a COG evaluation, which lets us look at that, and then you can get traumatic brain injury therapies that address those deficits that you find in your cognitive evaluation. Unfortunately, there's not a lot of treatment. What we do and what the evidence shows is the best thing you can do is to help people manage their symptoms until the brain recovers as much as it's going to recover. Most people with mild post-concussive symptoms will recover in a couple months. Most of those in a couple weeks. Again, the vast majority in a couple months, but there are going to be people who have lifelong symptomatology, and all we really can do is help manage that symptomatology. In terms of getting patients who have more severe dysfunction, to be honest, I'm not entirely sure about what resources are available here for TBI. I have noticed that it is challenging sometimes to get folks out of the hospital to the appropriate level of brain injury rehab, especially if they're children, if they're under 18. So, that depends on the resources in the community. Is there a TBI rehab available? Traumatic brain injury patients can be impulsive, they can be have some behavior issues, they can be difficult to manage, and so finding rehab locations that'll take them can be challenging. Does that answer the question?
Yep.
Okay.
And then the rehab part, they have to be attentive for inpatient rehab for a certain period of time, and so many of them aren't, and they're really caught in the middle. And then the guidelines, the ability to pay for rehab, it's hugely challenging for all centers.
So I'm just going to repeat what Denise said for folks who may not have heard. So there are so many barriers for patients getting rehab, including insurance and how much they can participate in rehab, that sometimes it's hard to get folks what they need. The reality is a lot of people with moderate or severe head injuries end up in a skilled nursing facility for the rest of their life because they can't participate enough in rehab to make it to a brain rehab institution. So they end up going to a nursing home. All right. Thank you for having me. I enjoyed this. If you want me to come back, let Mark know and give him feedback on what you'd like to see if I do come back. And for those of you, I don't know most of you because I haven't been here for very long, but I look forward to getting to know you. And if you see me down the ED, you have questions or issues, you want to see x-rays or something, just come talk to me.
All right, I think, thank you to Dr. Timmons. I think that was very good. One of the things that, so right now, what's your GCS for a trauma alert or a trauma team? What's your score? Not for intubation. So if you want to put get somebody, what's your trauma GS school say? Okay, 14 or less. Yeah. Remember, a year ago it was 13. We changed it to 14, mostly because of the persons my age. The thing is, we've by making it 14 instead of 13, you increase the sensitivity, the likelihood that you're going to discover a traumatic brain injury. You've increased that, but you decrease you increase the specificity. You make it more likely to diagnose or to be right that, yeah, this is a head injured person, so you're going to find these people, but you decrease the sensitivity. So more persons are going to end up being over triaged, but that's okay. We're okay, the thing is you you get 100 people that go into the ER as a trauma alert, and only one of them turns out to have a brain injury, that still has made a big difference. Just a little bit of cost shift. So, Denise Hahn-Taylor has a few comments and things to this. Are we still playing?
I don't need this.
Yeah, you need something because you got to play.
Right
You
here.
need to stand right here because this has to be done. Whoop,
I'm not using that.
No, leave that on.
I get that little red button right there.
No,
Do they need a little break?
turn that on.
Which this?
No, that middle one.
This one.
Denise, you're right here.
This
I'm
one.
not using this.
Yes, you are.
The PowerPoint? No?
No,
No,
you're
you
not
don't
using
have
the time, but you got to be on TV.
Oh.
Put that under there. Put that in your pocket.
Well, you know what? Actually, no, I don't want her on TV because then they're gonna.
Well, we've got to record her.
Well, should we? Let me do this. As soon as I turn that off, hit that button.
Which button?
The one it's on.
Yeah.
You don't need that, right?
Okay.
Should they have a break for
Now,
Okay, you need to stand over here.
stand over there so they can see yourself. There you go.
Oh, take off that
Okay.
15 pounds.
Go for it.
Okay.
You got to put that here. Flip it on.
I'll turn this way. Can you hear me? Yes. Okay. Is that loud enough? Well, it is till I turn
It's
away.
on there.
Okay. So I'll stand over.
Yeah, you're good.
Thanks,
So you're-
me. All
You're
right.
fine.
Good morning. Can you hear me back there? Is this thing, that's all right? My name's Denise Hahn-Taylor. I am the Trauma Program Director at Peace Health. It stuns me that I'm pushing 25 years, and I recognize some faces in here who have been here equally as long. But I will be, I think in June, been at Southwest and Peace Health for 25 years, and the last 17 have been in this role. So my background in my career has been pretty much all critical care. Couldn't wait to get in the ICU as a new nurse, and really kind of just stayed in that arena, whether it was post-open heart, trauma, ED, and then, I like the sicker the patient, the happier I was. So I think I was destined for trauma. So it's been a fun job and a good fit. Usually when I do this, I go into a bunch of history, but I'm not going to do that today. If you guys have questions, I'm happy to answer. I want to keep it a little briefer. I'm notorious for getting lost with my PowerPoint slides, so I thought I can get lost without them, so I have them up there. I get ahead of them, behind them. So my intent is just kind of to give you a current update on the state of the program, open it up to questions, anything, nothing's out of bounds, and just kind of be a little more conversational than flipping through my slides that I lose my place on. So the most recent thing for us is we designate every 3 years. They added a year this year, so it had been 4 years, the they being Department of Health. We went through survey at the end of September. It is really rigorous. They look under every rock in our trauma program and the services that support the care of those patients. In all the years I've done this, it was a stellar survey. The team, the physician was from Florida, the nurse was from a level 1 center. We are a Washington designated adult level 2. And it was really rewarding, the comments that they had. They really focused on the complex patients. They picked charts for us to look at, and then I just pulled some of the toughest, most challenging patients that we had, because we really wanted those objective eyes. And everything from massive transfusion, they comment on the EMS care and the quality of that care, the high quality of that care, nursing, our nursing education, and just really the ability to take care of these patients. So that was pretty awesome for me, and even more so because we have almost an all-new executive team in the hospital. We affiliated with Peace Health a couple years ago, and so there's been a lot of changes. So from where I sat, it was kind of like starting over in educating, and it was a great way to start. But more importantly, it just really spoke to the patients that we take care of. We are one of 5 level 2 centers in Washington, And we've had the distinction for quite some time of having the highest unexpected save rate. And that doesn't mean we just get lucky and the patient doesn't die. It means those patients are so sick. And when you do these, there's a formula for this, and I can't articulate it, which is fine. But what it does, it shows on the data that this particular patient really, for all intents and purposes, should not have survived and did. And so that's been consistent over the last probably 5-6 years. So it means for us that we're headed in the right direction with the care that we provide. I think that's the most important thing, and optimizing those outcomes. A little bit about our team. Last time I was here, I talked a bit. We've been recruiting physicians, and not that nobody wants to come work for us, not at all. It's just we are picky. It needs to be a right fit. It needs to be someone who can lead the team, manage the patients. And so our core team of surgeons has now all been on board. Tracy, we have one other surgeon that's been here a little less time than she has. So we're really excited about that. We have 4 trauma PAs now. And our trauma surgeons are just dedicated to trauma. They don't take other call when they're on trauma. That's a big move from when back in the day when we had general surgeons who were really busy also with elective cases. They welcome these patients. It's like, bring it on. We'll take, we're happy to take care of them. So that's been a really nice change. Our docs are all critical care trained and trauma trained. So when the patients go from the ED to the ICU, it's Dr. Timmons, it's that physician that you saw in the ED, that surgeon. They manage them through their course of the stay in the hospital, all the way through. The trauma surgeons are the overarch. They're the ones that coordinate everything. They'll call in the neurosurgeon, the orthopedic surgeon, and if any of you have ever met Kevin Kahn down in the ED, he's our orthopedic traumatologist. He does all the high-end pelvic fractures, and is really excellent. So we're lucky to have someone of that caliber along with the rest of the ortho team. But the trauma surgeons, that's a shift from way back. It makes the care more cohesive. It flows better. It's more seamless, and they keep track of what's going on with the other specialists. So they're the captain of the ship, which is really an optimal way to take care of those patients. Nursing also has specialized trauma education, and some of you have been to our trauma case reviews. That's just an extension of what we're trying to do to get information out there to our staff, and also to recognize everyone from EMS to rehab for their
one this week too.
Yeah, there is one this week on Thursday at 7 o'clock, and there's breakfast. So you're all welcome to join us. It's in the auditorium there at the hospital. A little about triage. I spoke that we're an adult level center. We're not a designated PED center. With that said, we'll take anything, resuscitate, and then if we need to transfer, we will. You guys do a great job triaging from the field with PEDs, but at the same time, if you say, we're coming in, we've got this, we'll take care of them and then sort it out later, because we don't have a PEDS ICU. And with 2 excellent PEDS centers, in the region, we're not headed that direction with PEDS. We're doing a lot of outreach. We go to the other hospitals up to Longview. We have Tracy and I recently went to Centralia. We want to just get out there and meet our partners in trauma care. And if there's anything we can do to provide support, but the other flip side of that is we bring back things that they're doing, which, I don't care what size center you are, there's some great innovation out there. I've been to places like Heppner, Oregon, that I didn't know existed. They get designated for trauma, and they do their little teeny tiny place in rural Oregon. And we have a lot of those in Washington, and some of the ideas they come up with, I bring back. They're awesome. So we just all keep working together to improve trauma care. A little about resuscitation. A couple years ago, I have no concept of time anymore, so I think it was 2012. We kind of broke down our whole resuscitation in the ED, started over, redefined roles. That's when the ABC, look at the patient, then okay, we'll take paramedic report, and okay, the straps can come off of the patient. We're going to revisit that. You tend to make these changes and they backslide a little bit, so you'll be hearing more about that. We're not going to do the 3-hour training that we did before. We're going to start doing scenarios in the ED, but we want to incorporate EMS in that. These will be really compressed, straight to the point. Here's our patient. Here's what we do. We just want to really refresh that in the minds of our team so we can. We've made great strides, but to maintain that is always a challenge. So we'll be in touch and always give us
feedback. The real
feedback.
thing was to make it consistent every time you came in, so that if you have one surgeon one night and another surgeon another night, it's not going to be different depending on the person. It's going to be, what the protocol is.
And the
Try to
surgeons,
make it a little less seamless.
they'll participate as a team lead. And the less sicker traumas, the objective is if we do it the same way every time, then we get the really sick patients. That anxiety factor is always present, but it's less of a factor because people are just used to kind of like the race car pit crew type phenomenon. So a little more coming up on that. The quiet in the room, I hope that there's been a noticeable change. I've seen it. It isn't always consistent. It used to be so loud you couldn't hear the paramedic report, but I've seen traumas now where it's ratcheted down. It's very easy to hear, but like I said, sometimes it can appear chaotic, but I need feedback from all of you on that. If you have ideas or from your end, what does that look like? Just if you see me or Libby, just Libby, who's right there, Libby Bryant, she's a trauma nurse coordinator at Southwest, used to be a paramedic and is a nurse. So give us feedback. There is that box where you can write a note on the counter behind the secretaries, and we look at those and take that to heart. A little about our quality improvement, and you guys are going to do a little of that. We have to do a very drilled down, detailed look at our trauma program. It's required, but it's the right thing to do. So we'll take different cases. We take cases that we've identified where, what the hell were we thinking? It didn't go as smooth as it could. And we look at all those and we learn from them, and we use evidence-based protocols so that we can measure our care, and we're working on developing more of those. But we want to know what we're doing right, and we want to know when it doesn't go as right as it should. And we're very transparent about it. The team that came in and looked at us, they identified in a couple patients. One, for example, was in the ED quite a long time with a pretty low pressure. They call it failed rescue. And on the other side of that was everything that we did to look at that case and things we had implemented. What was it, a communication problem? So what they were looking for is that we self-identified, and then again they spoke to the complexity of the care, which was really great. We have trauma multidisciplinary committee, we have trauma M&M, we have preliminary case review, we run data frontwards and backwards, so it really is a pretty complex process. I already spoke about critical care. Divert, everybody knows how I feel about divert. I absolutely can't stand the word. And we don't divert trauma unless our resources are maxed out, and that's the surgeon's call. We don't go on divert loosely because it seems like we're busy. We can take 3, 4, 5 traumas, but if 2 or 3 of them are going to go to the OR, that's pretty much going to, tie up our teams. We may have to say we can't accept anymore until we free up a surgeon, because that can pull 3, 4 surgeons into the OR. We work really hard at not doing that, and have been very successful, I think. Transfers, I know sometimes I get questions of, God, you guys, we brought you that patient, why did you transfer? Sometimes it happens a little bit in clusters. It certainly does with peds, because they'll come in and something blossoms that they need the peds critical care. Hand trauma, it's very low volume, but that microsurgery needed if the patient has, a guillotine type amputation, we'll send those out. But again, it's very low volume. We have facial surgeons now that can do the complex face injuries. Rarely do those go out. A rare orthopedic will go out, and then of course burns. We're not a burn center. We'll stabilize if we need to, and off they go to Emmanuel's burn center. But we want to do the right thing for the patient. And so where are those resources? Do we have them or does someone else have them? And we partner very well with OHSU and Emmanuel if there's a resource that they have and we don't. So, and you guys all knew KJ. You probably came into contact with him, Dr. Carmy Jones. He came here and spoke a couple of years ago. He's the trauma director at Emmanuel now. So, though he still does vascular surgery at our place, I saw him yesterday. So fortunately, he's not gone to us for good. I think that's really pretty much what I had. The types of our patients, as I spoke to, our acuity has gone up significantly. Our injury severity scores over time. Our volumes have also grown. We're challenged, like a lot of centers, you know, critical care beds they're either tight or you have a lot of them, and there's no rhyme or reason to it at times, but everybody balances that resource. We want to get those patients in and do the best that we can for them. And I'm happy to answer any questions if you have anything. Yeah. Rick. Hi, Rick.
Hey, are the on-call trauma surgeons housed in the hospital or off?
They have a required response time. For Washington and level 2, it's 20 minutes. We adhere to the American College of Surgeons standard, which is 15 minutes. So when they're on call, unless they live like 5 minutes away, they stay in the hospital. We have a call room up by the old ICU, and then there's one of the old houses right across from the hospital, which is the trauma call house. We also, I didn't mention it, we have about 4 docs that are core that come down from Madigan. They'll cover the weekends to give our team a breather, and they're excellent. Dr. Brown, Dr. Sebesta, you guys have all probably seen different ones of them. There's nothing they can't take care of, and they do an excellent job. So pretty much in-house call, yeah.
They're real good, but sometimes they're a little edgy because they're used to a little bit different systems, so they may get on your case. I've heard a couple of
Really?
medics say, "Oh, so and so was really bitchy at me today," but you know, it's that they don't expect certain things to happen that we do down here, which they're more likely to see the patient intubated here than they are up there. They're more likely to have you. I mean, you're gonna do an evaluation of their C-spine and whether they need it or not. A little bit more than they do up in the Madigan area.
Well, if you have a less than positive reception from our team, I want to know about it, because I do I cringe at the why is this a trauma? The trauma system is built with as high as a 50% over triage rate. If you call a trauma team, fine, you know, that's fine. We're going to respond, and we can peel the layers of the onion and go backwards from there if we need to. I want that over triage in the system. And a good example is recently a physician, he was new to us, not one of our surgical team, an ED doc, and he was kind of querying the EMS crew about why is this a trauma, and that said, and my comment was, let's take care of the patient, we'll talk about criteria later. And it was absolutely an appropriate call from the EMS side, and the physician just needed a little education. So I do follow up, but unless I hear from you, you know, I don't necessarily know. And you'll see me in the room, or Libby in the room sometimes. We come down just to facilitate, observe, be a resource if we can.
The expected deaths, the blue cards that we bring in.
The what?
The blue patients who are going to die.
Oh, yeah.
They're still trauma.
Other things I can answer? Mark has my email, my phone number. If you want, you know, we do follow up. If you're in there and you still happen to be there and we're back from CT, we'll tell you what we saw in the CT and our preliminary plan or what we think. Sometimes it's just a timing. So, well, thank you all very much for having us, and I just really appreciate what you do.
Remember, on the 11th, which is Thursday morning, 7:15, not 7 o'clock. It starts at 7:15. Be there earlier for breakfast. Have breakfast, and paramedics are more than welcome. As a matter of fact, we'd like to have you there because we like to have some input on the pre-hospital stuff usually. and I think Libby has probably talked to the medics who are involved in the case because often we'll have you present too. Don't get nervous about it. It's pretty straightforward. It takes a lot of bright lights and a stiff back chair and a little water containing thing, but we'll get the answer out of you.
Yeah, and if they invite you to an event, you're not on, it's just educational, it's not a quiz, it's not anything. We just like, the idea is to get the input from the entire team and their perspective, because we get some really good takeaways from that, so. All right, thank you.
Okay, I want you to take a 10-minute break. Yeah, 10-minute break, and we've got case reviews. There you go. Now kick that to get it out of the way, right? Okay. Okay. All right, a couple of cases. These are some trauma cases, and I may get Marty to make some comments too, because he's reviewed all these cases too. This was the Halloween evening. Multi-patient, one vehicle. Patient and others were struck by a car at high speed while walking on the sidewalk. Arrived to find a 32-year-old female attended by bystanders, patient 1 of 5 total patients. Patient conscious alert ×2, able to follow directions in apparent distress, had repetitive questioning, unable to remember any details of the incident. Patient was unconscious prior to arrival by bystanders, complains of pain in right arm and legs, denied shortness of breath. An obvious deformity to right arm, complaining of left leg pain, head pain, neck pain, back pain. Positive movement of all extremities and neuro. Patient's abdomen was soft and non-tender. Patient's pelvis was stable with no crepitus. Put that away for you. Or pain with palpation. Patient had pain to palpation of the left leg, possibly femur fracture, no deformity or crepitus with palpation, good cap refill. Here's the snapshot things. Cardboard splint to the upper arm, spinal precautions, full spinal precautions noted. Vascular access per protocol with IV site antecubital left. Tuck that away for your memory too, because it comes up again. Left pupil dilated, right pupil dilated, but about 6 millimeters. Reactive to light. Normal color, normal motion. The skin is okay. Vital sign. The GCS is 15. So she got a perfect score on that, although obvious head injury with a lung chimes. Lung sounds are clear. Glasgow coma score is recalibrated. It's unchanged. Blood pressure is 129/92. Pulse 90. Respiratory rate 20. 4 lead shows sinus rhythm. Antecubital IV starts noted again. Blood pressure 132/91, a little bit high for a 30-some-year-old person. Pulse 99, high, but maybe with pay attention, I guess, to the 91, to the diastolic. GCS has not changed. So, in the hospital. She was noted to be 32-year-old victim, autoped. Apparently the vehicle was traveling about 40 miles per hour, threw her approximately 60 feet. Confused, conscious, pain in right upper extremity, left lower extremity. Transported as a trauma alert. Difficult. Now, in the hospital, she had a difficult IV access. She had prior history of IV drugs, plus Hodgkin's lymphoma treatment and chronic pain. It ended up with a left femoral vein central line placement. ends up with a fractured dislocation of the right shoulder, reduced with under sedation in the emergency department. Non-displaced fracture of both inferior pubic rami and left suprapubic ramus in the pelvis. So although she had no pain on palpation, I don't know how aggressive the thing, and I'm happy not to have it too aggressive, but that it didn't show up. Distracting injuries, another reason to have good C-spine control. Left ligaments were, notice there's no apparent fracture of her femur, which is what pre-hospital thought was possibly fractured. Knee ligaments lax, no obvious fracture, put in a knee immobilized, remained stable, large dose of narcotics for pain control. There was a mention of a groin or vaginal laceration that may have been related to the pelvic fracture. The next hospital day, she was transferred to Legacy Emmanuel, primarily.
Well, I think it was one of her children also that was hit, and I guess it was for the logistics of just having her close to the critically injured child.
Because the child was critically injured.
I think this brings out a salient point about patients that suffer multi-system trauma, and that sometimes you, especially in the field, it's difficult to ascertain the specific injuries. Clearly, we have to think about everything that could potentially cause this patient to worsen and require interventions like surgery or some other interventional technique. In this particular case, the thing about the pelvis stood out, that she actually had a pelvic fracture that was occult. And it's important that we know what your exam is, because if you do have an exam in the field that shows pelvic crepitance or instability, we don't want to repeat that maneuver in the hospital because of the risk of causing more harm than good. We just want to know that that's what your finding was, so that we can image it and maybe decide whether this patient needs a binding or maybe intervention in terms of catheter-based coiling to stop any ongoing hemorrhage, because you can bleed a lot from a badly fractured or displaced pelvis, like we've talked about femurs, and there's a large potential space for that blood to go.
Yeah, pelvic fracture theoretically is good for 1 unit of blood for each fracture. And you almost never get only 1 fracture in the pelvis because it's a ring, and you can't fracture a ring on one side without having a little give on the other side too. So, now, a good pre-hospital care, including getting a line, including getting full C-spine. Case 2, patient dispatched an MVA, auto versus pedestrian. Patient has nothing to relate because they're unconscious. No one on scene knows the patient. Patient's supine on the ground, ineffective respirations, and unresponsive. Obvious fracture to left leg, abrasion to right hip and back. Patient being bagged, unable to place OPA due to trismus. Patient placed in full spinal precautions, moved to ambulance. Trauma team, code 3, unable to suction. RSI began, arrived at PH Southwest as sucks is pushed, and elected not to try to do the ET to delay transfer, moved right into the ER where they were literally immediately intubated. So, full spinal precaution. GCS is 3. Blood pressure is not taken, pulse was 96. Agonal respirations, rate of 6. 4 lead shows normal sinus rhythm. Pulse ox is 90%. So we've got our trauma head injury with hypoxemia. Lung sounds were okay, except not well assessed because of the obesity of the patient. blood suction from the airway, vascular access, antecubital, normal saline. No. RSI was begun. My only comment on this one is etomidate is given, and then patient went to succinylcholine. With a GCS of 3, do I need to sedate the patient? No. I mean, the protocol is you sedate the patient before you use time, but the understanding of that process, and no bitching about it really, but the understanding of that is we sedate people who have the likelihood that they're going to remember the procedure or it's going to be uncomfortable. GCS of 3, no. Don't waste the time. Paralyze them, succinylcholine alone. If they start to buck the tube after your wonderful job of intubating the patient, then you sedate them. This one doesn't. Don't take this away. It says, Dr. Whitwer says, don't sedate people. No, don't sedate people who don't need it. And certainly with GCS of 3. Now, if you say, well, in a 4, that's pushing the point too. But I'm not going to, so this one, you probably could have had time to intubate the patient, and then you say, God, I got a tube. Because I do believe that properly done RSI saves people. So, at any rate, patient is delivered. Now, this is a 31-year-old large female pedestrian hit by a car. Injury is agonal respiration supported with the BVM, intubated upon arrival at ED taking a CT, where she had biparietal subarachnoid hemorrhages and atlanto-occipital dislocation. This is the kind of patient that when they wake up, if they wake up, you don't ask them yes or no questions. She has an atlanto-occipital dislocation. Plus, for grins and giggles, a T2, T3 distraction injury with where the facets, the little side processes, the little secondary thing, they're now off kilter and hooked. So it's about ready to totally dislocate that whole section. But with the distraction injury, that kind of stretches the cord. Multiple other trauma. She had left tib fib. And this was bad enough that the left tib fib, she gets so much swelling, and there's the tibia and fib, very, very given to having, after the acute injury, develop extreme swelling. And it's another closed space because the reason you get shin splints is because it's a type of, if anybody here has ever had shin splints because they were, did an exercise they shouldn't have done without, warming up to it or being in shape. You get swelling inside the where the fascia surrounds the compartments of the muscles of in the lower leg, and it can swell quite a bit, and then it has no place to go, and it gets compression injury of the muscle. You basically kill the muscle with ischemia. The only way we get around this is to do what's called a fasciotomy. You take a knife, cut through the skin and the fascia, and peel it down to let it pop open so that the muscle can expand and not be squished to death. Then you have to go back after the swelling goes away and repair that fascial tear in the thing, but that saved it. So she required a fasciotomy of the left lower extremity. She went to the OR immediately, though, after the diagnosis of recessed spine injury, to have her cervical spine fused from occiput to C2, then had a T2-3 fusion subsequently, and subsequently surgical repair of the tib-fib injury. She has persisting neurodeficits. She's had a tracheostomy. She's had a gastrostomy for feeding and nutrition. Now, this was an interesting comment, though. I mean, you can comment about that, about the C-spine. She had a C-collar. She had good C-spine precautions on the way in, which is appropriate, but the neurosurgeon thought that potentially she would not do well with a collar.
Now, this is a pretty uncommon injury, and it's actually pulling the head off the neck. And so it's pretty unusual, and to make a rule for this particular injury that would vary with our normal protocol doesn't make sense. It's just kind of feedback that there's a potential for worsening in this patient if the head is further distracted. And it was not any criticism, it was just a kind of an acknowledgement that this was the particular pathology in this patient's case, and that optimally, if we had an ability to just transport without doing any maneuver of any sort and stabilize it, that would have been ideal in retrospect. But I believe that the collar was placed in the ED. And I don't know if she's a large patient, I guess.
Yeah, she was obese. That was trouble listening to the, and that might have, yeah. So I guess the trick is don't put the long collar that stretches in really a long way. But no harm, no foul. So that's okay. It's just an interesting after the fact thing. No change in your protocol. She needs C collar.
So it's a difficult airway from the outset when you arrive at the scene with an obese patient with a bad head injury and especially the trismus that was going on. I mean, that immediately makes you think, is this going to be a real challenge? And sometimes you can get, if the King, you're still using the King vision, right? For the video laryngoscopy, that can be helpful in these type of patients, especially with the bougie and the techniques that we talked about in our skills station at one time.
As a matter of fact, that would be the approach of choice.
The other thing I was thinking of, if you didn't have the trismus, it's using the supraglottic airway just to support them.
An eye gel.
The bag valve mask. Yeah.
But with the trismus, you couldn't get an eye gel in either.
No.
So, okay. Another interesting case. Two-car collision between a Jeep and a small four-door sedan. Date of service 10/28. This is going to be one where the hospital admits their own thing. Now, but we review all the trauma cases. We go over all the stuff, see what you could have done better, what you could have done, worse. And does anybody here think that any of the traumas, the level 1 trauma centers don't make mistakes? They get away with it because they're level 1 trauma centers. Because they review everything and say, oh, well, we learned a lot from this one. Yeah. Yeah. I was the subject of one of their reviews once because they missed everything that I had.
Well, maybe if you weren't in the trauma system all the time.
Yeah, they got tired of frequent flyer. He's here for drugs. Okay. Driver of a Jeep is walking around the scene, denies any injury. Driver of small car still sitting in car. Passenger ambulatory at scene, denies injury. Sedan has significant driver's side intrusion on front and back door, 1.5 feet. Broken side window, side airbag deployment, all occupants wearing seatbelts. Driver sedan complains of nausea, unable to remember event, but now alert and oriented. Complains of chest and left hip pain, denies neck or back pain. Placed in C-collar during extraction, removed from vehicle, took 10 minutes. Placed in full spinal precautions, transported code 3. Trauma alert. Pain scales 3 out of 10, spinal precautions. GCS is 15, blood pressure 162, 98 pulse, respiratory rate 20. Recheck blood pressure, 166. Pulse 92, regular. Rates 20, no change. So 39-year-old female, trauma alert, impact caused brief LOC, difficult extrication, vitals are stable, complained headache, back and hip pain. Hemodynamically stable in transport and the ED. CT scans didn't show any significant abnormalities requiring immediate intervention. Admitted to trauma for observation and symptom control. Discharged 2 days later. Pretty straightforward. But on the 31st, arrived to find patient seated complaining of shortness of breath early this morning. No bruising or trauma noted, transported code 1 for evaluation. She has her vitals were totally stable. Let's see. Pulse is, blood pressure still 150/80. Pulse is 80. Respiratory rate's 22. Pulse oximetry is 94 on O2. It was 92 on room air. Now that's the only abnormality really shown it, and that's not enough. That I wouldn't do anything differently except put a little oxygen to the patient. But even with O2, she's only up to 94. What are the reasons you have a low O2 saturation? Obviously, if you're not getting enough oxygen. Obviously, if you have a lung problem so that oxygen is not getting through. But what are the other things that give you somewhat low SaO2? The patient's too cold, hypothermia, skin perfusion. How about anemia? If you don't have enough hemoglobin to carry oxygen, well, we'll make a long story short on this one. So in the ED, she had a large left pleural effusion found and a left lower lobe consolidation. Well, that's called pneumonia. But a left pleural effusion, what could that be from? And of note, of course, we always get blood, and her hemoglobin hematocrit, which originally was 15 and 45, so 15 hemoglobin, 45 hematocrit, had dropped to 8 and 28, which is 1/2. So that's pretty significant blood loss. I mean, that's 3 to 4 units over the last few days. CT then, of course, showed the grade 3 splenic laceration and perisplenic hematoma, along with the left pleural effusion. Pleural effusion was drained. It had serosanguinous, bloody tinged fluid in it. So probably just from a contusion. That was drained with the chest tube. She was admitted, and her spleen wasn't actively bleeding. It was all this big perisplenic hematoma, 3 units of blood or so in the spleen, but outside the spleen, but stayed by the capsule. The current thought is that it's best to save spleens if you can, because the downsides of being without a spleen are infection, sepsis, and particularly to pneumococcus. She didn't require any transfusions. She built up her blood from that point. They just watched her spleen and allowed it to heal, to the hematoma to organize, and it won't break. And she was discharged after about 2 weeks, which is kind of a trade-off, having an operation, remove your spleen, and then spending the week in the hospital probably offsets the cost of staying 2 weeks for just watching it. But you end up with a better spleen after the deal. So, and in retrospect, the radiologist and the trauma surgeon said, well, really, you know, it looked like a little skiff in the spleen on the first set of CT scans, and in retrospect, it might have been better to do serial hematocrits if they were following, to do another CT scan right after that. But she seemed remarkably stable. Now, this is not an uncommon thing. We see spleens coming in from all over the country with, where they've been in a car wreck and they show up 5 days later with, shortness of breath and drop in hematocrit, and this thing happens. So, but this is the kind of thing that we will watch and report when we make a mistake.
One other point about that, and especially with spleen injuries, is instead of taking the spleen out, they can do procedures to save the spleen. Particularly the interventional radiologists, they'll do embolization of bleeding areas. And,
right.
So, especially in kids, non-operative management is really critically important, like Lynn said, about your immune status for the rest of your life, and preventing to have to take antibiotics and be super careful about protecting yourself against that future infections. So it's really important, and I think the trauma surgeons are trying to work their way out of a job so that a lot of these things are taken care of without immediate operative intervention.
Yeah. It's almost considered malpractice nowadays to take a spleen out on a child, because kids with splenic injuries do remarkably well. They heal pretty fast, and they don't seem to have it. So it's very, very rare.
A good point about repeating your exam and looking for changes from the initial findings, because in this case, in the hospital phase, it was, if we had checked serial crits, maybe we would have found a dip in the thing and then had to investigate. Well, why is this happening? Where's the bleeding going?
Yeah. They say now, even if you've got a fractured spleen and the potential that it's going, the radiologists go in and put coil in the splenic artery, because the spleen is supplied by collateral circulation that does really well. So you put the coil in the splenic artery, cut that flow down to almost nothing. Spleen gets its supply from the collaterals, and it does really well, because then the pressure is reduced tremendously. So, okay, switching from trauma. 58-year-old male, supine on the bathroom floor, carried to kitchen and CPR started. Roommate of patient says he heard the patient fall, called 911. Patient pupils are pinpoint, skin is warm, pink, and dry. Has 2 agonal respiration in the first minute after EMS arrival. So, compressions are begun. Oxygen patches placed on the patient, and he's diagnosed as ventricular fibrillation. Also, naloxone nasally is given, which is appropriate for pinpoint pupils and the sudden collapse. Manual shock, number 1 for VFib, and then there's an error here. It says post-conversion rhythm atrial fibrillation. That's, I think, just the way that the AMR's thing clicks out. So it did it twice here, because, okay, then no change, continue compressions, shock 2. And again, it says post-conversion atrial fibrillation, not true. Still, so medication, epinephrine given, and rock ALP study, number 1, 1A and 1B, manual shock 3, once again says the same atrial fibrillation, not true. Blood glucose is checked, given some more naloxone. Shock 4. Rhythm now it says asystole, but we didn't check that. They gave epinephrine and they gave the ALP study. Now, I'm not sure the times are exactly correct on those things because the ALP study should have been given above there. Capnography is 19. Patient gets more epinephrine. Capnography is still 19. Patient is transported. I-gel we used for the pre-hospital airway. Code was continued. They RSI'd and they did an ET apparently, and they had ROSC. Had transcutaneous pacing in the ED, followed by along with dopamine. Central line cooling cath. Patient was started on hypothermia protocol. EKG didn't indicate a STEMI. The next day, however, he has a slightly elevated troponin, so they did have some cardiac muscle injury. The troponin is your enzyme test. Angiogram the next day showed non-occlusive 3-vessel disease. Echo showed hypokinesis of his right ventricle. Treated for cardiogenic and septic shock, probably due to aspiration pneumonia, which occurred prior or at the same time he was being intubated, I imagine. Had a rocky course, ultimately improved and is actually discharged from the hospital, 11:10. Do you remember where he was discharged home, or did he go to a...
I can't recall. I don't think it was.
Okay. So he had his ALP study drugs, he had continued for the VFib arrest, elected to continue. A lot of people, after that many things, would say if you didn't have ROC at the scene, you might not have transport. They did transport him. He did pretty well, all things considered. I suspect with his 3-vessel disease, non-occlusive 3-vessel disease, they may have put in a ICD ultimately. I would have wondered if they wouldn't have put in a ICD. So a few glitches maybe in the exact timing of the rock drugs, but the rock drugs got in. So ALPS refresher. Now, I'm going to make a comment that be sure when you're shocking the VFib rhythm, be sure that it's a VFib rhythm and not an organized rhythm. Okay, my only comment. We've had a couple lately that when we reviewed, they said, "Oh, these are definitely organized rhythms." So, ALPS inclusion, non-traumatic out-of-hospital cardiac arrest. You need vascular access. It can be your IV or IO. Persistent VFib or VTAC after 1 or more shocks, which means you can't give the ALPS until you've given at least 2 shocks. Okay? No, and you can't use open label amiodarone or lidocaine in the field. We had just an error recording. It said they used lidocaine. They didn't. It was Versed for bucking the tube after the fact. And of course, we have the usual people we can't do it on: prisoners, minors, pregnant persons, trauma deaths, etc. And those are the no study bracelet. But we have yet to see one. Almost everybody out there wants to be resuscitated, I guess. What counts as a shock? Any rock agency administered shock, any first responder BLS AED, any ALS delivered shock, any public access defibrillator at a public access point, but not your ICD shocks. They don't count. we can query any of the other machine, but there's no AED out there that you can make shock that will tell you to shock a non-shockable rhythm. By definition, VFib pulses VTAC. So confirmed, if the machine said shock it, that's confirmed. Confirmed VFib. If you say it's VFib, it is, unless it's organized rhythm. Pulseless means anytime you're going to need CPR. And anytime after the second shock, you need 2 shocks. If you're thinking antiarrhythmic drug, if you say, in the good old days, they said, oh, gee, I got to give them amiodarone. We don't know this stuff works. That's why we're doing the rock. So anytime you think dysrhythmic, you think give ALPS. Now, we will give it usually after we give epinephrine. Now, epinephrine, you can give it in the same sequence. Now, just for your grins and giggles, there's another very well done study, not a retrospective done in Japan, but a European study, which indicates, which the conclusions of the study is, if epinephrine is given pre-hospital for cardiac arrest, the patients have a decreased neurological and survival rate leaving the hospital. But the real interpretation of that is that if you don't need to give epinephrine, that means you've had early CPR and early defibrillation, usually by laypersons. That's probably the take-home message. The fact is that if the patient is in ventricular fibrillation long enough to require epinephrine and more intervention, like this guy, like the last guy, a long time before resuscitation, they're going to, by definition, do worse neurologically. The guys who respond to the first shock and wake up and start holding you back when you're trying to do the second shock, they're going to do pretty well. The study drugs need to be given as soon as possible, and we try to get them in within 10 minutes. So usually within the second or third round of your ACLS, after the second shock. If VFib VTAC returns, you do the full ALPS procedure. So you start out with ALPS procedure, which is number 1A and 1B, and then you go to 2 the next time. And that's just a single vial. If you got ROSC back after 1A and 1B, and then later in the transport, the patient goes back into VFib pulses VTAC, give them that second dose of the other dose of ALPS drug. If anytime VFib VTAC occurs in the course, if you're transporting a patient who's having a STEMI and they go into VFib VTAC, if you need 2 or more shocks, you go right to the ALPS procedure at any time. First dose is 2 syringes, unless you're a little itty bitty teeny weeny tiny person. Then it's only 1 syringe. Second dose is 1 syringe, ordinarily. If VFib VTAC recurs after you've used up all the study drug, you can use magnesium, additional shocks, additional epinephrine, but you can't use any open label amiodarone or lidocaine. You've got to use ClearLink adapter. I'll be so happy when the study is over, because then we won't have to worry about ClearLink. They have a delivery system for it now that doesn't require the ClearLink, so of course, but and you have to use it because the Luer lock isn't compatible with the syringe setup for the ALPS thing. So you have to put the ClearLink on, and then attach the syringe a little half turn to make it click on, and then it goes. If you enroll the patient, you call that number. It's written in you don't have to memorize it, because we have to enroll all the patients or notify them that they have been enrolled or their family. Then they can no longer participate, but all your data up to that point is still good. We've not had anybody turn it down in Clark County that I'm aware of. Just have to let Marty and the people and the hospital ER folk know that the patient's been enrolled in ALPS. Nowadays, it's no big deal. Originally, it was a big thing because the docs say, oh my God, what drug can I use on the patient now? Well, it doesn't really make any difference, but would have to adjust the dose of lidocaine possibly. Document. What you normally do in case of cardiac arrest, if it's your monitor used, put it down as your monitor. If it's Vancouver Fire's monitor, put it down as that, because that's what we're going to query, the PCO file. Timestamp, if you can, as you can, when the syringe number of the ALPS drug. So syringe 1A and 1B, syringe 2. Document the shock number that precedes and follows the dose of ALPS drugs. Just document and put in the barcode. Any questions on ALPS? Okay. For everybody's information, even though mostly the requirement or the responsibility for this lies with AMR, because they're the only ones who carry the syringe and all, is that we do have the sudden unexpected death study going on as well. This is Sumit Chug's thing where they're doing genetic tagging of all persons who have had a sudden cardiac arrest, whether they've had return of spontaneous or they popped up and said, hey, I'm feeling better after that shock. If you get we say, is there any genetic thing that predetermines whether people will go into cardiac arrest? And yet it turns out, yes, there are. He's not ready to release all of those things yet, but there's some family genetically determined characteristics that we maybe can make some interventions on ultimately. So all patients who could be in the SUD study, or any patient with a pre-hospital cardiac arrest, even if you give them ALPS drugs too, even if you've had ROSC, we only exclude traumatic deaths and overdose. If the patients died because they took an overdose of opiates before you got there, that's not a cardiac arrest. Draw blood as soon as feasible after your IVIO start. We don't need much blood. It's just a simple little syringe. Label the tube, name, EMS number, date of service. Include a copy of the hospital face sheet if you have one. If you don't have one, you don't have one. But everything is supplied baggy. This is AMR. And put it in the fridge at headquarters, and it's taken care of by John and other people at AMR. So just remember, we should put a little sticker up that says remember SUDS. Theoretically, you could draw blood at any time. However, I can't authorize you to draw blood on a patient just for a study. You can draw blood if it's part of starting an IV, then you're not assaulting the patient. You've not done anything. If you draw blood on a dead body, unless you're the coroner, you're assaulting the patient's body. So we can't let you do that. But so if you think SUDS, if you think you've got a cardiac arrest, I'm working the patient, I'm starting an IO, I'm starting an IV, I'm going to get a little blood at the same time I hook up everything. That's cool. And we don't expect it will happen every time, and it doesn't. But if you think about it, it's nice because I'd like to get it over with so that Sumit can get on with it. He doesn't call us. Okay. Anybody have any thoughts or any questions or any issues? Okay. We are going in the month of January, so January will be skills month again. And January will be dedicated again to our cardiac arrest and our mega codes, and we're gonna try to design them to beat you to death on that thing, because we've got to keep up with, even people who've been in the field a long time, things fall off. Now, you guys do the best CPR and the best cardiac arrest stuff in the county. I mean, if you're gonna have your cardiac arrest, have it in front of the fire station or in front of AMR's office, I guess. Not in front of mine. Okay, so have a good holiday.
Yeah, just going up there. Out of my way.